Hi, good afternoon.
There we go. Thanks, Mark.
Hi, thank you for taking the time to join us for today's briefing, Maternal Mortality in America, Understanding the Challenges and Crafting Population-Based Solutions. I'm Mark Mather. I'm the moderator for the event today, and I'm with the Population Reference Bureau, or PRB, which is located right here in Washington, D.C. I'm also a longtime member of the Population Association of America, or PAA, which is sponsoring today's event. And for those who are not familiar with PAA, it's a professional association with more than 3,000 population scientists. That includes demographers like me, sociologists, economists, and epidemiologists. And these scientists conduct research on the individual social and environmental causes and consequences of human population change. We have three distinguished scientists with us today: Dr. Robert Anderson with the National Center for Health Statistics, Dr. Amanda Stevenson from the University of Colorado-Boulder, and Dr. Alecia McGregor from Harvard University. PAA is also grateful for the support of several co-sponsoring organizations, including the American College of Obstetricians and Gynecologists, the American Statistical Association, the Association of Population Centers, March of Dimes, PRB, and the Society for Research in Child Development. PAA also thanks the Office of Representative Brian Fitzpatrick for reserving this room and for helping us to promote today's briefing. They're not listed in the remarks I just gave, but I do want to also thank Mary Jo Mitchell, who's Director of Government Affairs at the PAA, and staff at CRD Associates for helping to organize this event. Population scientists, including some of today's panelists, rely on funding from the nation's scientific research agencies, especially the National Institute of Health and the National Science Foundation, to support their research. The maternal mortality data and findings that are featured in today's briefing underscores the critical role that federal scientific and statistical agencies play in population research. This research also shows how population scientists inform policy issues and make significant contributions toward improving the nation's health and well-being. PRB is particularly pleased to be co-sponsoring today's event because we recently worked on a maternal mortality awareness campaign called My Last Lullaby, shown up here in this slide. We did this work in partnership with an ad agency called Tank Worldwide, and this was a campaign to help raise awareness about the high rate of pregnancy-related deaths among Black women in the United States. And it started with a PRB research brief that highlighted research funded by the Eunice Kennedy Shriver National Institute of Child Health and Human Development, or NICHD. I can tell you that at PRB we've written a lot of briefs over the years, and sometimes we ask ourselves, does the world really need another research brief? But this is a good example of how a simple brief can turn into something much bigger, because it grew into a whole social media campaign and a video that was really a unique project for us, because it combined the data and the research with a very personal story. And it's a sad story. It's about Dr. Shalon Irving, who was a CDC epidemiologist before she died of pregnancy-related complications. And we told this story in a short video that recreated Dr. Irving's voice digitally as a last goodbye to her infant child. And I admit, we were sometimes uncomfortable with this campaign because we're demographers and we're scientists, and we've always focused on data-based advocacy. This work started with the data, but then it became focused very much on appealing to people's emotions, as you will see in this video.
Twinkle, twinkle, little star, I wish I was where you are, up above the world so high. Now I'm not there when you cry. Twinkle, twinkle, little star, oh, fair health care feels so far. Hear my voice and raise it high. This was my last lullaby. I'm Dr. Shalon Irving, and I died on January 28, 2017. But my voice lives on. The maternal mortality rate is 3.5 times higher for black moms in the US. Donate at mylastlullaby.com and together we can put systemic racism in healthcare to bed.
So at the PRB, we report on statistics, we report on rates, percentages, patterns, and trends. But this video, I think, is a good reminder that there are people behind all of these numbers. So keep that in mind, in the back of your minds as you listen to today's presentations. Just a few housekeeping matters before we begin. The speaker's slides, their bios, and a recording of this event will be posted on the PAA homepage after the conclusion of the event. If you didn't get a packet, you will receive a link to all of the information in the briefing packet via an email, as long as you submitted an RSVP or signed up at the registration desk. And the speakers here today are not here to advocate for specific policies, and any positions that they may express are their own, and they don't necessarily reflect the positions taken by PAA. The speakers will each take no more than 10 minutes. I will then moderate a question and answer session at the end. And during the Q&A, we will turn off the live stream so that you can identify yourselves and ask questions freely. Thank you for your attention. I will now turn it over to Dr. Anderson.
All right, good afternoon. So I'm going to be talking primarily about data and measurement issues with regard to maternal mortality. And I'll just start by talking about where the data come from. Maternal mortality information come from the National Vital Statistics System, which is a cooperative arrangement with state and jurisdictional vital records offices. We have 57 jurisdictions that participate, 50 states, New York City, which is separate from the rest of New York State for vital records for some reason, District of Columbia, and 5 territories. We have a contractual relationship with them to provide data, and then those data go into the national statistical file and become the National Vital Statistics System. We do this with births, deaths, and field deaths. With regard to maternal death, the National Center for Health Statistics follows the World Health Organization definition of maternal death. I mean, there are a lot of other definitions out there, but we focus on the definition that is a death while pregnant or within 42 days of termination of pregnancy. And that, of course, is irrespective of the duration, site of pregnancy, and from any cause related to or aggravated by the pregnancy, but not accidental or incidental causes. So we're not counting suicides and homicides as maternal deaths. Although different measures of maternal mortality may, like pregnancy-associated mortality, may include those types of deaths. But for international comparative purposes, we use the WHO definition, and that excludes those deaths. Then we also count late maternal deaths separately, and those are from deaths occurring from 42 days to 1 year. And those are calculated and counted separately. And then I'll just mention that we use ICD-10 codes currently to classify maternal deaths, and we've been doing that since 1999. This is an image of the standard death certificate format. All of the states use this basic format in their state death certificates. I'm not going to go into great detail here, only to mention that it's typically divided into 2 pieces. Part 1, which is a causal sequence leading to death, and Part 2, which includes contributing conditions. Prior to 2003, the standard death certificate did not include any sort of prompt with regard to pregnancy. And so we had to rely on the cause of death certifier to mention pregnancy in one of these sections in order to count it as a maternal death. And if it was a clear obstetrical condition, that's pretty easy, but if not, then that makes it much more difficult to count if the pregnancy isn't mentioned in those fields. So the result was that we were substantially undercounting maternal deaths. And the research has shown that it ranged anywhere from 30 to 70% undercounting. So to address that, in 2003, the standard certificate was revised to include a checkbox item asking about pregnancy. It seemed like a really good idea, and overall, I think it has been, but it hasn't been without problems, and I'll talk to you a little bit about that. So here we're trying to get the certifier to indicate, the status, the pregnancy status of the decedent relative to when she died. One of the problems that we had was that not all states implemented this checkbox item at the same time. And you can kind of see from the animation of the slide how that sort of played out. We had 5 jurisdictions implemented in 2003, and then implementation was incremental over time as a result. We spent a fair amount of time studying this. I won't stay on this slide very long. You'll have access to the slides, and so you can go and look these up. But we did spend a lot of time studying this issue. Now, if all of the states had implemented that checkbox at the same time, we would have seen this sort of obvious discontinuity in maternal mortality rates. There would have been a big jump with the implementation, and we could have easily seen that that was a statistical artifact due to better counting. But what actually happened because of the incremental implementation of the checkbox item is we ended up with this trend that makes it seem as if maternal mortality is rapidly rising in the United States during this period. So the implementation of the checkbox occurred over about 15 years and wasn't fully implemented in the United States until mid-year 2017. So 2018 was really the first year that we had all states with that checkbox item. Now, as I mentioned, we did a lot of study on this, and we determined that if we assume that everyone had the checkbox starting in 2003, that maternal mortality rates were actually relatively stable. They weren't increasing dramatically, but they were considerably higher than where they were without the checkbox. And if we assume that nobody implemented the checkbox, we ended up with essentially the same pattern, just at a much lower level. And so, we thought that, as we were going along, that sort of we were solving this problem. It was inconvenient, and we had to stop showing maternal mortality rates for a while because it was, we felt like it was misleading what was happening. But we thought, okay, we're solving the problem. And to some extent, we were, but as we dug in to the data more and the issues more, we realized that there were some other issues. It turns out that pregnancy checkbox is prone to error. And we were getting some false positives with that checkbox. And of course, we're getting false negatives as well. So if the checkbox isn't checked, we're going to miss deaths very much like we would have otherwise. So fortunately, the false positives are largely sort of compensated for by false negatives, but the false positives end up in the older age groups. Still, we ended up probably overestimating a bit with regard to maternal mortality. So to deal with this, we made some coding changes. I won't go into great detail here, but the upshot is that we stopped using the checkbox for women over 45, to compensate for that. So if it was an obstetric or pregnancy-related condition that caused the death, we still counted it regardless of age, but we didn't use only the checkbox to identify maternal deaths to do that. And that helped us to mitigate the false negatives. So the orange, I think it's orange on there, yeah. The orange line there shows what's happened since 2018. And you can see the 2018 level is a little bit lower than what we would have reported based on the previous coding scheme. But you can also see the big increase there during the pandemic. And this is not due to checkbox. So this is sort of a real increase. And you can see here that that increase is almost entirely due to maternal COVID. And we do know that pregnant women were particularly at risk of severe COVID infection and died. Many of them died as a result. So just going back here real quick to the revised coding line there, I just will mention that provisional data for 2023 so far is still not official, but the provisional data are showing that we're right about back down to pre-pandemic levels, which is good news. Although the rates are still much higher than it should be. Okay, so just really quick as I wrap up here, just wanted to mention some of the things that we're doing. We are monitoring the quality of coding to identify errors. We have training materials and tools. We have a program with many of the states to try to verify the pregnancy checkbox information through record linkage and things like that. And then what we hope will happen going forward is that we can address some of these issues in real time rather than trying to sort of fix things after the fact. We'd like to engage the cause of death certifiers in real time and maybe ask them some follow-up questions to try to deal with any errors that might occur with regard to the checkbox. So things like a confirmation screen if they've indicated a pregnancy or a question about the outcome of the pregnancy. And so I'll stop there and turn the time over to Larry.
Well, we're very lucky to have Bob here to explain the measurement of the maternal mortality rates to us, because let me tell you, that's something I spent a lot of time explaining to stakeholders from across our country. So you're very fortunate to have him explaining it to you, not me. I'm going to talk about something a little bit more contentious, which is the question that has recently entered the public debate about whether or not maternal mortality is increasing and whether or not it's high, whether it's overestimated. There has been a claim that maternal mortality in the United States is not as high as estimates place it at. And we just heard that there are some issues with the maternal mortality rates that come from one of the sources with overestimation, but of course there's also underestimation. And there would be underestimation if we used alternative methods, more underestimation than we currently have. So I'm going to just discuss briefly another source of data on pregnancy-related death in the United States, which provides a longer time series with consistent measurement, which shows that there has been an increase over time, looking over a longer time scale. This is the Pregnancy Mortality Surveillance System, PMSS. These are deaths that are verified by medical epidemiologists. Each death is investigated And this investigation is used to assess whether or not a death is actually associated with pregnancy. This is based on a host of data, and it takes a long time to conduct. It's important to distinguish between the pregnancy-related deaths that are associated with, that are identified in the pregnancy mortality surveillance system, and the pregnancy-related deaths that Bob was talking about in maternal mortality rates. They're not just different because they come from different data systems, they're also different because they cover different periods of death with respect to the end of pregnancy. So NCHS maternal mortality rates, which Bob was discussing, include deaths during pregnancy up to 42 days postpartum, and the pregnancy-related mortality ratios, or PRMRs, which is how we abbreviate that, include all deaths that are associated with pregnancy-related causes up to a year postpartum. So measuring different things in different ways, but similar efforts, measurement of similar constructs, deaths due to pregnancy-related causes. One of the things that looking at the pregnancy mortality surveillance system data allows us to do is describe the distribution of deaths across time. So about a quarter of deaths occur during pregnancy, 11% occur on the day of delivery, and then the remainder of deaths occur after delivery. So most pregnancy-related deaths occur after delivery. So this is just the maternal mortality rates 2018 to 2020 that you already saw. But the pregnancy-related mortality rates, the ones that come from the pregnancy mortality surveillance system, provide a longer time series, and you can see that there is a gradual increase. But this period when the maternal mortality rates from NCHS have this rapid increase that's associated with the implementation of the checkbox is actually relatively flat in the PRMRs. So the upshot of all of this is that we have validated data that show that maternal mortality in the United States is very, very high, and that those data demonstrate that it has been increasing over recent decades. So just to turn to some of the demographic characteristics of these deaths, this is a transition. In this graph, the top line is 35, so that's 35 deaths per 100,000 live births. Now the top line of the graph is 65 deaths per 100,000 live births, so we've radically extended the y-axis. This is necessary because I'm going to show you the rates of death by race ethnicity. Because deaths are so disproportionately experienced due to pregnancy-related causes among people who are Black, we have to extend this axis this high. So that's the green line. And so what the sort of upshot from this graph is that there have been consistent race ethnic disparities in maternal death in the United States as long as these data have been calculated, and that the disparities have consistently identified Black women as having the greatest levels of death. American Indians and Alaskan Natives have very, very high levels of death as well, and in the first year of the pandemic, or the 2021 births, so the first year, well, the most severe year of the pandemic with respect to pregnancy-related death, American Indian and Alaskan Native deaths actually occurred at higher rates than Black women's maternal deaths. Okay, so in terms of the US rates being high or low, they're very high relative to peer nations. So these are the other G7 nations. You can see that our rates are much higher. The nations that have more similar rates to us are Latvia, Mexico, Turkey, Romania, so other high-income nations, but not as high as us. So in terms of identifying population-based strategies to reduce maternal deaths, there are basically two pathways of causal action. The first is that you reduce the rates at which people who are pregnant die due to pregnancy. This requires interventions at a variety of levels, and luckily our third speaker is going to discuss this because this is outside my area of expertise. But the thing that I know as a demographer of fertility is about the effect of exposure to risk. The risk of pregnancy-related death is only present if you're pregnant, and it's greater if you stay pregnant for longer or get pregnant more often. So if you don't want to get pregnant, and then you get pregnant anyway, that increases the risk of you dying due to pregnancy-related causes. As a consequence, fertility and pregnancy rates shape the level of pregnancy-related death in a population. And things that influence fertility and pregnancy rates, namely access to the means of controlling fertility, are also going to shape the rates at which people die due to pregnancy-related causes. So this is access to abortion and contraception, as well as the ability to carry pregnancies to term when one wants to. So thank you very much. I'm happy to take questions in the Q&A.
All right, good afternoon, everyone. So thanks so much for being here. My name is Alecia McGregor, and for the past several years, I've devoted my own career to studying maternal health equity and the role of health systems in promoting equity and safety during childbirth. And this work is both personal and professional for me, as I'm sure it is for some of you. It's personal because a little over 12 years ago, one of my sisters suffered a terrifying complication after giving birth to my nephew in a South Florida hospital. She had a very severe case of postpartum preeclampsia, and she was hemorrhaging for several days after her delivery. This episode led to her spending about 2 weeks in the ICU out of about a 3-week hospitalization, where she underwent intubation, sedation, and hysterectomy, dialysis. She was transfused several pints of blood and more. So needless to say, this was one of the most harrowing experiences of my life and of my family's life. At the time though, I was a grad student at the time, I wasn't aware of how my sister's experience was indicative of the broader pattern of risks facing Black women and birthing people in the United States. But fast forward a few years later, I worked as a postdoctoral research associate in Princeton, New Jersey, and I started to learn about the changes taking place in the maternity care landscape. I learned that the neighboring city of Trenton, the capital of New Jersey, majority Black and Latinx city with high levels of poverty, relatively speaking, that the city of Trenton no longer has any maternity wards within the bounds of the city, and that maternity wards were rapidly closing across the state. And now, fast forward to today, right here in Washington, D.C., as we speak, there are no hospitals with obstetric services operating east of North Capitol Street, the street that divides the eastern and western portions of the district. And I know many of you probably live in or around Washington, D.C., and so you must know that Northeast and Southeast D.C. is home to the greatest concentration of Black residents in the district, and also a relatively greater concentration of low income and high poverty neighborhoods. And so today, we meet at a moment when maternity care is tragically absent from the communities that need it most. And for the next several minutes, I'll be speaking with you about some of the data, the public health data, although my colleagues have covered it pretty nicely already, and some of the policy opportunities and policy options we can leverage to make an impact here. Now, let me turn straight to the numbers. Although the US spends by far the most on healthcare than any other nation in the world, we have the highest rate of maternal mortality among OECD nations, so the highest income nations in the world. And as Dr. Stevenson showed earlier, if you take a look at that bar on the far right, so this is a chart that was compiled by the Commonwealth Foundation using 2022 figures. And that bar on the far right represents maternal deaths among Black individuals in the US. And that bar, and just how astronomically high it is what keeps me up at night, and I think is what should give us all pause. And again, Black women are almost about 3 times as likely to die of pregnancy-related deaths than their white counterparts. And recent estimates show that Indigenous women are about 4 times as likely to die than their white counterparts as well. But maternal mortality, while it's alarming and should stop us in our tracks, it's just the tip of the iceberg of the maternal health crisis. So by some estimates, for every maternal death, there are as many as 70 to 80 instances of severe maternal morbidity, which are those life-threatening illnesses that occur in or around childbirth that require life-saving interventions to save the person's life. So kind of like what my sister experienced 12 years ago. And here on this chart, I'm showing severe maternal morbidity rates in the state of Massachusetts between 2011 and 2020. And here you can see that Massachusetts has experienced a near doubling of severe maternal morbidity rates in this time. And that's considering that Massachusetts was recently ranked one of the best performing health systems in the nation, and we spend more than most states in the nation on healthcare as well. So this is pretty troubling. And when we look at those trends by race ethnicity, we see that racial and ethnic disparities are pervasive here as well. And so this top line, the dark blue line, represents severe maternal morbidity among Black, non-Hispanic folks in Massachusetts. And you can see that that rate is about twice the rate of white women in Massachusetts. So why do we see these persistent inequities? So that's a question that several scholars are hard at work trying to answer, including myself and the folks that I work with. And there's a lot that we still don't know. However, here I'm listing a few of the leading explanations, and in the interest of time, I will focus on those explanations that center around healthcare and health systems factors. But I'd like you all to note that each of these explanations have systemic racism and structural racism at the center. So taking a look at the question of unequal distribution of appropriate care during pregnancy and childbirth, we know from the evidence that Black and Hispanic women are more likely to receive a cesarean delivery that's not needed, and even when they have no clinical indication that would warrant C-section. And there are a number of risks that come with cesarean birth. It's a surgical procedure that comes with risks to both the mother and the infant. And with respect to health systems challenges, today I'll focus my attention on the phenomenon of the widespread occurrence of obstetric units across the United States, which is the topic of much of my research at the moment. So what do we know about OB unit closures? For the past few decades, obstetric units have been leaving both urban and rural communities across the US, and often some of our most vulnerable communities. And when OB units close, they close either via the closure of the entire hospital or just via the closure of the obstetrics department alone, while the remainder of hospital operations remain. And in the first decade of the 2000s, more than 10% of all hospital OB units closed in the nation. We know that from work by Dr. Pei-Yin Hung at University of South Carolina. And more recent work, looking at closures between 2010 and 2022, shows us that these rates remain high and they vary substantially by state. And in fact, Washington, D.C. is among sort of the top 5 states with the highest rates of OB closures in this time period. And what are the implications vis-a-vis racial inequities? So the literature started to tell us a bit here as well, but turning to some work led by my research team in New Jersey, we studied the impact of OB unit closures on severe maternal morbidity for those zip codes that lost their nearest obstetric unit between 2006 and 2015. And what we found was that for those women who delivered in a period after their nearest OB unit was closed, they had a higher likelihood of experiencing severe maternal morbidity than those who delivered while their nearest OB was still open. So we know that OB unit availability and proximity is important for outcomes. And finally, I'd like to wrap up my time by talking a bit about what's happening right here in the nation's capital. And Washington, D.C. itself has been the site of a dramatic reduction of hospital obstetric services for the last 20 years. But in 2017, The last two obstetric units in the eastern portion of the district closed their doors, leaving the only hospital OB units in the northwest quadrant of the district, which many of you know is the most affluent section of the district. This is happening at a time when DC's maternal mortality rate is almost twice the national rate, and Black people made up 9 out of 10 pregnancy-related deaths, according to the last, most recent maternal mortality review committee. And taking a look at the pattern of racial residential segregation in DC really helps put these closures into context. Now, DC is a starkly segregated place. The visual I'm showing here shows the percent Black population by census tract. This visual was put together by the Legal Defense Fund. And here you can easily see that the further south and east that you travel in DC, the more likely you are to find yourself in a neighborhood that's as much as 95% Black. And the further northwest you are, the greater likelihood you have of being in a neighborhood that might be 1 to 5% Black. And so in our research, we set out to find out more about how people living in the easternmost wards of DC, wards 5, 7, and 8, were accessing care. And what we found was alarming. We found that, number one, that there are severe capacity constraints in Washington, DC at the moment, constraints in the number of obstetric beds, constraints in terms of the number of clinical providers, and there's also a not insignificant occurrence of diversion, where obstetric departments are actually diverting patients because they're at capacity. And so this is a very substantial disruption to one's plan of care when they find out that the hospital that they intended to deliver at is in fact a hospital that they can no longer go to. So it definitely poses risks to safety in many ways. So where do we go from here? How can we ensure that maternity care can survive and thrive in the neighborhoods that need it most? So I'll leave you all with two broad areas that, in my view, are the critical areas for needed intervention. And I know at this point, I'm very hopeful because I know several members of Congress are already drafting and introducing legislation, probably members that each of you work with. So I'm excited about this moment that we're in. It's hopeful, especially as the CDC tells us that 80% of pregnancy-related deaths are preventable. And so these two broad areas for intervention include transforming the payment environment that we find ourselves in. Our current hospital payment environment certainly undervalues obstetric care and the sustainability of obstetric units in vulnerable communities. So let's continue to focus legislation on payment. And then finally, transforming the composition of the maternal care workforce to bolster midwifery and doula care. All right, so I'll stop here. Thank you all for your questions and feedback, and look forward to the discussion.
Thank you. So you've heard some alarming statistics, and I'm going to try to just briefly summarize what we've heard. Dr. Anderson described some of the challenges in estimating national level trends in maternal mortality in recent years, and the introduction of a pregnancy checkbox that has improved estimation, and kind of summarizing the fact that the U.S. maternal mortality rate is high and would have been even higher in previous years had that checkbox been adopted in all states sooner. Dr. Stevenson then asked if maternal mortality in the U.S. is high and increasing, and her research based on 2 sources of maternal health data suggests that the answer is yes. Pregnancy and birth have been getting deadlier for women by either measure. And there are also severe racial disparities in maternal death rates and very high maternal mortality in the U.S. relative to peer nations. And then finally, Dr. McGregor provided some of the explanations for racial inequities in maternal mortality and morbidity related to the closure of obstetric units. She points to these closures in rural areas as one of the key factors, And I was also really struck by the statistic that over 80% of pregnancy-related deaths are preventable. So I think before we open it up to the group, I wanted to see if any of the panelists wanted to respond to any of the other panelists' remarks. Any comments or follow-up questions? No? Well, I just want to start with one question. It's a broad question that really gets to the big picture about U.S. compared to peer nations, because this is not something we see just with maternal mortality, but I think with some other health statistics. So why is it that the U.S. is lagging so far behind other high-income countries, and what can be done to fix this issue? And I think that maybe you started to look at some of those factors, but anything specific you wanted to mention?
Clearly a big question. Thank you. Thank you so much. So clearly a big question, and I think the answers are, lie in long-standing facts about U.S. healthcare in general and the origins of our healthcare system. I think compared to peer nations, the U.S. has not adopted a system of universal healthcare access. And in fact, our healthcare system was built on top of a long history of racism and a legacy of Jim Crow and a legacy of broad swaths of the population in the Southeast and in the Northeast and all over the country who had no access to healthcare, who gave birth at home or else had to give birth in the basement of hospitals or in the sort of segregated wards of hospitals. And so the huge inequities that drive our high rates are in part because of this long-standing history of racism and the lack of universal access to healthcare that our health system was built on.
I'll just add, the rates are also likely due to highly stratified levels of physical health before pregnancy that are the result both of these systems and other systems of stratification in the United States that make maintaining health something that not everyone can achieve.
Thank you.
If I can also add, because the weathering was another leading explanation that I didn't get a chance to get into, but I think it adds to what Dr. Stevenson just mentioned, which was the sort of very disparate rates of chronic diseases in racially and ethnically marginalized populations. So the weathering hypothesis, I don't know how many maternal health people are in the room or how many have heard of this hypothesis, but it was developed by Arlene Geronimus at Michigan. And it essentially refers to the fact that sort of repeated exposure to stressors, environmental stressors, the stressors of racism throughout one's lifetime leads to wear and tear on the body that makes, for instance, Black women more predisposed to chronic illnesses at a younger age, right? So illnesses like hypertension, these are showing up in Black women and birthing people earlier, and these are the types of chronic diseases that increase an individual risk for pregnancy complications. So definitely very important explanation.
Thank you. We have about 15 minutes, so I did want to just open it up for questions at this point.
And I would just say before questions, we do not have a microphone for the audience. So like I'm doing now, please speak up and project. Thank you.
Yeah, we have turned off the mic.